Welcome back to the Ninja Nerd Podcast. Today we've got a brand new episode for you on breast cancer. We're finally moving on. We're out of heme.
I know. How long were we in that? About 7 years?
7 years. It seemed like that, right?
Definitely was a while. So it's nice to move into a new topic. Oncology is a big topic filled with lots of different things to discuss. But breast cancer is on the docket today. And I think there's a lot of important things that should be made known, educated about. And again, we'll focus a lot on diagnostics and treatment, but I think a big discussion on prevention. So
that sounds great to me. It's going to be a pretty cool episode, packed with information. We hope you all enjoy it. Let's just get right into it.
All right, hit me.
We have a 52-year-old female presents with a newly discovered breast lump during a self-exam. The patient noticed a firm, non-tender mass in her right breast 2 weeks ago. She denies pain, redness, or nipple discharge. No prior breast lumps or abnormal mammograms. She presents with no fevers, weight loss, or fatigue. She also reports mild retraction of the nipple and says that her bra has felt tighter on that side. For her past medical history, we have hypertension, type 2 diabetes, hyperlipidemia. She's currently on lisinopril, metformin, and atorvastatin. For her family history, it's pertinent for breast cancer at 45 for her mother and ovarian cancer at age 50 for her aunt. So pretty pertinent family history there.
Yeah, usually when you hear that, you think of BRCA, but we'll get into that.
BRCA, okay. For her exam, vitals, BP 130 over 85, heart rate is 78, and her temp is 36.8 Celsius. For her breast exam, we have a 2.5 centimeter firm, irregular, non-tender mass in the right upper outer quadrant of her breast. For nipple changes, we do note mild retraction with no discharge. We do a lymph node assessment, and we note a mobile, non-tender, 1.5 centimeter right axillary node. So when you hear that, Zach, what's going through your mind?
I mean, you got a female here who is 52. I mean, you can make a chance and say that they're postmenopausal. I don't know completely when it was, but you know, they're presenting with a mass in this non-tender, irregular mass in the right upper quadrant, upper outer quadrant. That's a common area for breast cancer, and that's obviously what we're talking about. So anytime a patient comes in with symptomatic lumps or bumps in the breast tissue, there's a pretty large differential. Obviously, the focus here is thinking about what makes it seem more suspicious for breast cancer. So upper outer quadrant is pretty common for breast cancer. Non-tender, firm, irregular, but then axillary lymph node involvement is pretty common. The other thing that really kind of screams breast cancer here is the mild retraction of the nipple and then the breast asymmetry. So whenever they say that the bra is felt tighter on that affected side, that tells me that there's probably an enlargement of that breast, some more asymmetry. Mild retraction of the nipple is very common, especially with breast masses. Then they get like tethered onto the Cooper's ligaments. Those Cooper's ligaments or suspensory ligaments are supposed to keep the breast kind of like lifted up and tight. In this scenario, if it gets kind of tethered onto them, it can pull on those Cooper's ligaments and shorten them, which can kind of invert the nipple or even the skin around where that area is. So that's pretty kind of ominous and a concerning feature here for a patient with having breast cancer. The other thing is the family history. So I kind of like chimed in there about the BRCA mutation.
Yeah.
So BRCA mutations are really important to consider, especially in a strong family history. So having a mother with breast cancer at 45 and an aunt who had ovarian cancer at the age of 50, it's pretty common for BRCA mutations, BRCA1 and BRCA2 mutations, especially the BRCA1. If you have those mutations, you're at high risk for both breast and ovarian cancer. And so having a family history of both breast and ovarian cancer in two family members is kind of suspicious. We don't know that, but definitely a family history there that suggests the likelihood of breast cancer. And then the other concerning feature is that whenever breast masses start off, they kind of remain solitary to either a duct inside of the mammary gland or a lobule in the mammary gland. But when they break past that basement membrane, they start invading into the soft tissue. The next place that they can go is to the lymph nodes, and the axillary lymph nodes are the first one. So having a right axillary lymph node in such close proximity to that mass suggests that there's probably already some small amounts of spread there potentially. So there's a lot of things here that scream breast cancer to me, to be honest with you.
Let's get some initial imaging. When we think about imaging, we're trying to give the best diagnostic tool here. What are you thinking for first line?
So there's always the difference between screening imaging and diagnostic imaging. So screening is a patient who's asymptomatic. This is a patient who's symptomatic. So when they're symptomatic, we use diagnostic tools. So you kind of imagine an algorithm and you develop a schema to separate out at one point. So let's say that I have a patient who is coming in. They have symptomatic things like this, where they have the breast mass, some axillary lymphadenopathy, some nipple retraction, things like that. and then they're less than 30 years of age, that usually warrants a breast ultrasound, just because of more like the density of the breast tissue to really get a look and see, hey, what does that mass look like? Does it look irregular? Does it look like the architecture is a little bit weird? Does it have some calcifications associated with it? Those are things that are more concerning, and that's something that you may need to do a biopsy of. So we usually less than 30, breast ultrasound. If they're greater than or equal to 30, the guidelines have said that we should do a diagnostic mammography, and most of the time follow up with a targeted breast ultrasound. So you do both for older than 30 or greater than or equal to 30. So this patient is
52.
52. So we're going to put them in the algorithm to say they fall into the diagnostic mammo plus a targeted ultrasound afterwards. And then based upon that, I would determine what I would do next to see what it looks like.
Well, let me help you paint the picture here. We have the results for this mammogram, and the mammogram shows a spiculated mass with microcalcifications. Ultrasound reveals a hypoechoic irregular mass.
Yeah.
What's your next move?
That's a suspicious lesion to me. And so we use any kind of report when you get a mammogram or an ultrasound, especially when it's about the breast. The radiologist will report something called a BI-RADS score. And so it goes BI-RADS 0 all the way to 6. 0, the imaging was incomplete, wasn't helpful. You probably should just order another one, redo it. 1 is it's pretty much normal. 2, it's most likely benign. And then 3 is it's probably benign, which you should probably get a closer follow-up, maybe like 6 to 12 months, get another ultrasound or get another diagnostic mammo. But if it is greater than or equal to 4, that is a suspicious lesion, and you need to go ahead and biopsy that. And so at this point, I would say that this is a very concerning lesion when I hear spiculated, irregular appearing, microcalcifications. Again, I would need the official radiology report, but I'm going to go and say that this is definitely greater than or equal to 4. It's screaming that to me. So I'm going to get a core needle biopsy where they can do this ultrasound guided. They find the mass, they take a needle, and a pretty decent sized bore one. You go into that mass and you pull off particular tissue. Your goal is to see if that tissue is cancerous or not. And so that's what I would need next to definitively determine if this is definitely cancer or not.
Now, you've mentioned a core needle biopsy. Are there other types of?
There's excisional biopsies, which you do in the OR. We don't really do those too much. And then the other one is they used to do fine needle aspirations. That's always the wrong answer. So funny enough, fine needle aspirations, the only time that they really would be considered is if you have a patient who had an ultrasound, they get like a cystic looking mass. So then they would say, okay, try to do a fine needle aspiration and pull off some fluid. If you pull off bloody fluid, that's possibly malignant, send that out to be confirmed. But also if you don't really pull anything, then that's also something that's concerning too. So usually we can use fine needle aspiration to determine if we pull back kind of bloody-ish appearing stuff, and that suggests more of a malignancy as compared to like a fibrocystic change or something like that. So that's something that's really important is, fine needle aspirations can be utilized, but oftentimes if they come back bloody, you most of the time are going to send that off and get a core needle biopsy instead. So core needle biopsy is always going to be the gold standard in this scenario.
We do get the core needle biopsy, and the results are back. We have a invasive ductal carcinoma and a couple of interesting markers here. We have an ER/PR positive, HER2 negative.
Yeah, that's another.
Could you elaborate on that?
Yeah, that's another reason we get core needle biopsies, because you need a core needle biopsy to tell you if the pathology's like if it's abnormal or not, what kind of tissue it is. But you also run immunohistochemistry on that biopsy sample to look for specific markers that are present on or in the cell. And so invasive ductal carcinoma, that is the most common invasive breast cancer. So if you remember the types, and so this is just a quick little run through, there is what's called carcinoma in situ. And so this is ductal carcinoma in situ, that's very, very common. And lobular carcinoma in situ, that's less common. Those are your non-invasive ones, which means that they have malignant appearing cells in those actual lumens of the duct or the lobules, but they haven't broken past the basement membrane. Once they break past the basement membrane, it's invasive. And so that's when we get invasive ductal carcinomas, which account for 70 to 80% of most of invasive breast cancers. You have invasive lobular carcinoma. It doesn't account for a large proportion. And so that's not as going to be a common one. The scary one, and this is usually the one that whenever it presents at such a late stage, is inflammatory breast cancer. And so this is one where the malignant cells arise in the terminal ductal lobular unit, and then they like fling off these like little micro tumor emboli, if you want to think about it. They get and they move into the dermal lymphatics, obstruct them. Usually it can affect one breast, but it can do both. And then the dermal lymphatics they get so obstructed that they can't drain lymph from the breast tissue. And so the breast tissue gets super swollen, edematous, enlarged, red, painful. And that's inflammatory breast cancer. So that picture doesn't support inflammatory breast cancer. And again, I would be able to differentiate between invasive lobular and invasive ductal just based upon my biopsy. There's another test. I don't think they do it too often, but you can check the E-cadherins. They love to ask that on the exam. So let's say that you got a tissue sample, and on the exam they said, we got the tissue sample, and it looked that whenever we stained for the E-cadherins, there was a loss of E-cadherins. That always suggests invasive lobular carcinoma. So sometimes they'll freck with you on the exam with that, but oftentimes if you get a pathology report, it's either going to say invasive ductal, invasive lobular, but on the exam, if they say, oh, pathology came back, it showed that the immunohistochemistry did not stain for cadherins, or there was less, that's invasive lobular. So that's a little exam tip there. But in this case, invasive ductal is the answer. And then estrogen progesterone, so ER/PR positive, that means that they are overexpressing specific receptors on those malignant cells. So estrogen receptors, progesterone receptors are upregulated, and HER2 are not upregulated. So HER2 is for epidermal growth factors, and so it helps with proliferation of breast tissue. This is really, really, really important, because the whole point of this is it tells me what kind of therapy I can utilize against this cancer. So obviously, depending upon the stage of cancer determines things like surgery, radiation therapy, and chemotherapy. But another really important thing that comes in with treatment is targeted therapy. This could be endocrine, this could be potentially monoclonal antibodies that you can use. And so you want to know what that is. Are they ER/PR positive? Are they HER2 positive, or are none of them positive, which is called triple negative breast cancer, which is a really scary and aggressive one. In this case, since it's ER/PR positive, that means it's hormone driven. We can give anti-hormone therapies. So for example, if a patient like this has ER/PR positive, I can give them, maybe we'll do surgery, maybe we'll do a lumpectomy for this patient. Maybe then after that, we'll follow up with radiation therapy, and then we'll put them on adjuvant targeted therapy. So for this patient, I would start something like tamoxifen or an aromatase inhibitor. Again, it depends on if they're menopausal, pre or postmenopausal. So premenopause, we do tamoxifen. And that's going to target the estrogen receptor. It basically, imagine it plugging into the hole where the estrogen binds into, blocking it, and then estrogen can't stimulate the breast tissue to proliferate. So you're stopping the proliferation. Aromatase inhibitors basically inhibit the conversion of androgens like testosterone and dihydroepiandrosterone, prevent all those from being converted into estrogen. So it kind of therapeutically lowers your estrogen levels in the body as well. And so again, that lowers that proliferative effect on the breast tissue. So that's what I would probably reach for right away. If it was HER2 positive, in this case it's HER2 negative, but if it was HER2 positive, we use a monoclonal antibody called trastuzumab. It blocks the HER2 receptor, so epidermal growth factors can't hit on it, and you can't send signals to proliferate that tissue. But that's, in this case, we don't need that. So we'll talk a little bit here in a second, but they're probably gonna need surgery, probably a lumpectomy, followed up with radiation therapy, probably some adjuvant chemotherapy as well. But I'm definitely gonna do, I'd say in this case, depending upon if they're premenopausal, tamoxifen, postmenopausal, and aromatase inhibitor, and we don't need trastuzumab. Funny enough, I know I'm going off a tangent here, but trastuzumab is kind of an interesting drug. And one of the benefits of this drug is, again, it's great in HER2-mediated breast cancer. So if that came back with that, I'd use this one. Problem with trastuzumab is every drug obviously carries side effects. Tamoxifen carries the risk of clots and endometrial cancer. Aromatase inhibitors carry the risk of osteoporosis. Trastuzumab carries a really potential effect of cardiomyopathy. And so it can have cardiotoxic effects. It can lower a patient's ejection fraction. They may need to get a lot of serial echocardiograms. And so that means a lot of monitoring. And on top of that, this drug, let's be real, is not cheap. It can be pretty expensive sometimes. And so that's another thing I'd say about trastuzumab.
And even with insurance, patients will still face huge out-of-pocket costs. And can you imagine that? That's brutal. You're a patient who's been diagnosed with breast cancer, and then you've got this amazing therapy, but it's incredibly expensive.
Yeah.
It just doesn't seem right with having a diagnosis like that. It's unfortunate.
Even medical professionals aren't immune to like a lot of these financial stressors and stuff like that. I mean, being a student, you face student loans. You got to figure out your own personal finances. If you have the ability and you want to invest, you even have to figure that stuff out too. And so it's easy, I think, to get overwhelmed in the aspects of medicine. As in, you know what I mean?
It's exactly why this episode is being sponsored by the Millionaires in Medicine Club. It's a free resource designed to help medical professionals at any stage, from training to practice, learn how to navigate student loans, investing, and personal finance so we can feel financially stable. We can feel good about ourselves and knowing that our future is secured. Let's check it out.
If you're a medical professional or you're training to be one, you may have noticed that six-figure salary doesn't go as far as you thought it would between a rising cost of living and the dreaded student loan payment. That's exactly why we created the Millionaires in Medicine Club, where clinicians and medical professionals in training can come together to learn student loan strategy and ways to actually build wealth. All you have to do to get access to the free community is click the link in or around this video. Twice a month, we actually pay financial industry experts like financial advisors, CPAs, real estate investors, student loan consultants to come in and teach you all the stuff you should have learned about money in school that you didn't, so that you're equipped to turn your six-figure income into a seven-figure net worth as a medical professional.
Dude, I'm going to sign up for this too. I mean, insurance, I'm going to be honest with you. A lot of my financial planning is geared towards, my credit card's not, getting denied at Chipotle, but I could be better with my personal finances.
I feel that.
Investing in student loans. So absolutely. I'm going to check this out too, man.
I think it's time to get back to our patient.
Yeah.
enough fun for a little bit.
Yeah.
What's the next step with our patient, Zach?
So there's a couple other things I would say that we need to do. So remember I told you that we got to determine, do they need surgery? Do they need radiation therapy? And do they need adjuvant chemotherapy or neoadjuvant? Really, the best way of determining that is we have a lump. We need to, I'd want to go back, reassess what that mammo or ultrasound showed the size of the mass to be. So that's one thing. And then I want to just look at other staging. So we have to use what's called the T&M staging and really kind of determine, okay, first off, what's the tumor size? I can get that from a lot of different things. If the patient happened to get a breast MRI, you can get it from that. If you get it from an ultrasound, you can get it from that. A diagnostic mammo, you can get it from that. So I just need that tumor size. That's going to be super helpful. Lymph node involvement can oftentimes be clinically done. So if I'm palpating and I'm doing a breast exam and I find also when I get into the axilla that I feel some lymphadenopathy or I feel kind of an enlarged lymph node, I want to clinically determine, does it feel like I can move it around and it appears to be mobile? Or does it appear to be really, really fixed, hard, matted around?
Which in our patient, it was mobile.
Yeah, so that's kind of a little bit more of a positive sign. It doesn't necessarily mean that there's not tumor cells in there, but it does have a potential differential where you have to think, is this benign? Is it reactive? Do they have an infection going on? Or is it metastatic? Whereas if I go and I palpate and I feel like a really rock hard fixed node, I have to suspect that this is malignancy until proven otherwise. And so in this case, it is mobile. It is enlarged though. And so I would have to really I'd still probably go ahead and consider, what do I need to do with this? I probably want to biopsy that. And you can just do a core needle biopsy right into that lymph node as well. If they didn't have any nodes that were positive, so you were palpating around, you didn't feel anything, then what you can do is, let's say we stage them and we say, hey, we're going to go ahead, your stage fits with getting a lumpectomy or a mastectomy, where we're going to go into surgery, remove the tumor. Depending upon if it's lumpectomy or mastectomy, you have to remove more tissue. Yeah. But while they're in there, we can do something called a sentinel lymph node biopsy. Really, really cool test. What they do is they take a radiotracer dye, stick it into that tumor, inject it into it, and it moves, and that radiotracer will light up a particular lymph node where the tumor cells have spread. And so that's actually really, really helpful because it makes sure that we just don't go in and just cut lymph nodes out. We're only going to remove lymph nodes if it's truly needed, because when you cut a lymph node, you actually you increase the risk of like lymphedema, other nerves that are running through there. And so there's a lot of complications that we try to avoid, what's called axillary lymph node dissection. So for this one, I'd probably biopsy the lymph node as well, just to be safe. Also determine if there's tumor cells there, but if it wasn't even palpable, after I go ahead and do a lumpectomy or a mastectomy while I'm in the OR, you'll do something like a sentinel lymph node biopsy.
And would you still do a sentinel lymph node biopsy even if, let's say for her, our patient, she had one lymph node that we were able to evaluate and we were able to appreciate that?
Yeah.
Would you still do that biopsy to try and find others?
Yeah. So that's the thing. If I biopsy this one, that's going to tell me if that node's affected. But when I'm still in the OR, you should still do a sentinel lymph node biopsy. And here's the reason why. Is depending upon maybe more that you missed and weren't palpable. Yeah. If you light up 3 or more of those nodes, then I have no choice but to go and cut those out. And so that's really, really important to remember. Absolutely. If you palpate it, core needle biopsy. But if they have a lumpectomy or mastectomy, you go in, you do that sentinel lymph node biopsy to see if there's more greater than or equal to 3 lymph nodes that are lighting up like a Christmas tree. The only other thing I would add to this is one more critical feature to treating a patient with breast cancer is has the cancer spread beyond the lymph nodes to distant sites. Bone is a scary one, brain's a scary one, liver and lungs. Yeah. And so the only time we do that is if they have symptoms that suggest that. Not every patient who has that, you just go ahead and you say, let me get a pan scan of their entire body, etc. In this case, the patient doesn't have any symptoms that suggest that they're having brain mets, lung mets, liver mets, or any kind of bone mets. And so I don't need to go ahead and do any kind of like invasive scanning there. That's provider preference. And so maybe you do want to do that. The guidelines suggest that you only scan their brain if they're having things like headaches, seizures, focal neurodeficits. Get an MRI of brain with contrast to say, oh, it's spread to the brain. Do they have abdominal pain? Is their LFTs a little bit bumped? Then maybe get a CT of the abdomen and pelvis to look for the liver mets. Do they have shortness of breath and cough and recurrent pleural effusions? Maybe get a CT chest to see if there's lung involvement. Are they having bone pain like in the back or in the arms? Are they having a history of recurrent fractures? Or, what we would see for this patient is sometimes, which is kind of scary, is you can see elevated calcium levels. And so hypercalcemia of malignancy can also be present because you get the cancer into those bones and they chew the bone up and they get these lytic lesions. So hypercalcemia that pops up and it's acute, that's also a sign of malignancy. And the other thing is if they have spinal cord compression, because sometimes the tumors can get there as well. So in this patient, I would say I probably don't need to go and get any kind of further imaging. I would probably biopsy, core needle biopsy, the lymph node. Based upon that, again, see if there's tumor cells in there, but most likely I'm going to be doing a sentinel lymph node biopsy in the OR for this patient anyway.
Well, our patient had a diagnostic mammogram, and this confirmed a 3-centimeter mass, and with our sentinel lymph node biopsy confirms 2 suspicious axillary nodes. All right. So again, we did have one that we were able to evaluate, but this tracer caught another one.
Yes.
No distant metastases.
Good.
Now I want to figure out the staging. You had mentioned the particular staging method we'll use for this patient.
Yeah, so it's the T&M staging. So it goes off tumor size. And we can pop a table up to follow along. But tumor size is actually pretty helpful here because we kind of go, if it's T1, it's usually what we would say is less than or equal to 2 centimeters. If it's T2, then we say it's between 2 to 5. And then if it's T3, it's usually going to be somewhere where it's greater than 5 centimeters. And then as you go up, it invades things like the chest wall, the skin, the nipple, things like that. N is usually like clinically done. So we actually look to see if the node is mobile or if it's fixed. And so usually what we want to know is N0 is it's kind of like we don't have any nodes that are present. So it's clinically node negative. N1 is they feel like they're kind of mobile, right? And then what happens is eventually as we continue to get worse, we start seeing, oh, this patient has fixed nodes. Or do they start involving other nodes like the clavicular, the supraclavicular, infraclavicular nodes? And then M is for distant metastasis. So has it spread to multiple organs? Has it spread to the bone, to the liver, to the brain, to the lungs? So in this case, I could say that there's no distant mets. So M is 0. For the nodes, they do have clinically node positive disease, but it's mobile. So we're going to call that N1. And then on top of that, they have a 3-centimeter mass. So again, T1 is less than or equal to 2. And then if it's 2 to 5, that's T2. This patient fits as a T2, N1M0. And then when you look at this, we'll plug this table up there. It actually fits this patient perfectly into stage 2, but we're going to say it's stage 2A breast cancer. T&M is kind of annoying and there's a lot to it, but I think it's best to start off with figuring out the T and M components and then seeing how that fits into your stage. Stage 1, stage 2A, stage 2B, stage 3A, stage 3B, C, and stage 4. So there's a lot of stages, but this one's stage 2A.
For our patient, now that we know it will be stage 2A and we've got the staging all figured out, what's our treatment plan?
So we use the terms of stage 2A and stage 2B and stage 3A, all that stuff like that for diagnostics. It's more of just a kind of a guidance. But oftentimes when it comes to treatment, we boil it down to if they're stage 1, stage 2, stage 3, stage 4. It's really annoying to kind of do that, but that's kind of what we boil it down to, is what true just overall stage are they in. So when a patient comes in and they are stage 1, we actually say it's most likely it's a small tumor, and it probably hasn't really extended to a lot of lymph nodes yet. And so for that, I would want to do like a surgery. I'd want to remove that lump, do some radiation therapy to that area, and you're probably going to reduce the risk of any kind of recurrence of that breast cancer forever. There's always a chance it could come back, but you do a pretty good job with lumpectomy, radiation, and maybe adjuvant chemotherapy. For stage 2, it's kind of the same thing, funny enough. So stage 2, you do a lumpectomy, you do a radiation therapy, and you can potentially do the adjuvant chemotherapy. Again, where I would add on to stage 1 and 2 is that, remember I told you the targeted therapy for this patient? They were ER/PR positive. So tamoxifen, if they're premenopausal, or aromatase inhibitors, if they're postmenopausal, would be good. So for this patient, they're stage 2. So I'm going to start off with, let's get you ready. Let's start off with a lumpectomy. And then while you're in there doing a lumpectomy, we already did it, but we're going to do the sentinel lymph node biopsy. Came back, showed that they didn't have more than 3, greater than or equal to 3 positive nodes. So we don't need to cut out a bunch of lymph nodes. So we'll just do a lumpectomy. After they're done with their lumpectomy, let's really shrink down the tumor and get rid of any kind of micrometastasis or micro tumors. That's where you're going to hit it with radiation therapy. So you're going to hit the cancer there in the breast and near the axil with radiation. After that, or around that time, you're going to continue targeted therapy. So I'm going to put them on tamoxifen or an aromatase inhibitor. And then I would also order what's called an oncotype diagnosis score. And it's basically like imagine it as like a test that tells you what's the likelihood of them responding to chemotherapy and what kind of chemotherapy you would need and just overall risk of recurrence. That's what I would do. I would get what's called an oncotype diagnosis or a MAMA test. They have all these different types of tests, but it just tells me how well they react to the adjuvant chemotherapy and if they need it. If that onco test really comes up telling me that they need it, I'll add in adjuvant chemotherapy. Usually, it's most of the time doxorubicin, and then a taxane like paclitaxel. So those are the things that I would say for this patient is let's just lumpectomy, radiation therapy, put them on a tamoxifen or aromatase inhibitor, and then on top of that, use the oncotype scoring system to determine if they need adjuvant chemotherapy. That's what I would do for them.
Great. Well, that would be the treatment, and that's really the case for our patient and how we're going to go from start to finish with her. Now I would like to just highlight a couple different things, some special cases, some special considerations, and maybe any high yield points you have left.
Hit me.
You had mentioned earlier about triple negative breast cancer. So
Yeah.
I am curious to know a little bit more about that.
Man, triple negative breast cancer it's kind of a beast. It's a scary one. So yeah, you brought it up. It's kind of like when you get that core needle biopsy back and it shows, let's say it's invasive ductal carcinoma, but it shows that the estrogen receptor, progesterone receptors are negative. So there's 2, and then HER2 comes back negative. That's 3. So if you have negative markers for ER, PR, and HER2, that's triple negative breast cancer. And so that's a pretty aggressive one. Usually there's not like a targeted therapy as compared to like what we would use for HER2, like trastuzumab, and then ER, PR, which is like the tamoxifen or the aromatase inhibitors. There is like one, I think it's called pembrolizumab. We use it for the PDL1 positive triple negative breast cancer. And so it can be something that you add on to chemotherapy. Oftentimes it's just chemo though. You're going to be putting them on things like doxorubicin and the some kind of taxane like paclitaxel, sometimes cyclophosphamide. But yeah, this is a pretty tough one. Triple negative breast cancer is a little bit more of a challenging one to manage.
How about no longer considering the TNBC, but what if the patient is if they have breast cancer and they're pregnant, what do you do then?
Oh my gosh. Well, that makes things really hard. Well, radiation therapy's out. You probably have to wait until they're at least postpartum for that one, because that's exposing the fetus to radiation that increases the risk of a lot of, teratogenic kind of like properties. Tamoxifen and I think aromatase inhibitors are also teratogenic. So, they're not ERPR positive, but so you don't have to worry about those. But if they were ERPR positive, you probably wouldn't be able to use that either until at least, they're postpartum and even maybe even a little bit past that. I would see no issue with lumpectomy or mastectomy if that was needed.
Yep.
You can still do that because that's not going to harm the fetus in any way unless there's like postoperative, like or intraoperative complications like blood loss. But lumpectomy, mastectomy would be fine. Chemo, it kind of just depends. So chemo is obviously a little bit of a tricky one if it's needed, especially which is in triple negative breast cancer. You could probably do it, but you should probably wait, I'd say, at least until the third trimester, maybe. But that's a Pat question. That's something that would take an oncologist for a ride for sure.
Yeah, that's a tough one.
Yeah.
Luckily, our patient's 52. I don't think she's pregnant. No. Hope to God she's not pregnant.
No, I hope not either.
Well, Zach, before we wrap everything up here, let's discuss prevention. The most important thing here is saying, well, how do we even prevent breast cancer from happening? Well, if breast cancer is going to happen, it's going to happen.
Yep.
But how do we identify it immediately and treat it? Because it's very treatable early on.
Yeah, it's important to prevent it. But, you want to try to catch it, as you said, before it gets to stage 4, right? You don't want to catch somebody who comes in and they had a breast lump, and then on top of that, they got mets in the brain and the bones and things like that. So screening is really, really crucial here. So one of the big things that we can do is screening. Remember I told you that there's a difference between screening imaging and then diagnostic imaging?
Sure.
So for screening, we use what's called a screening mammogram. And so there is limited views. It doesn't take as many of the views that you need from a diagnostic mammogram. And so that's probably going to be one of the biggest tools that are utilized in these patients. But sometimes we'll even do breast MRIs. And so that can also be involved. But I think the really important thing is that for every patient, so this patient, you start to wonder, what if we screened this patient a little bit earlier?
Yeah.
Could we have caught something even earlier? This isn't bad, it's stage 2, but could we have caught something even maybe a little bit earlier? And so that's where you'd have to use something called a risk assessment. There's all these different breast cancer risk assessment tools. I think there's one like the Gale model, but I think the newer one that radiologists and a lot of clinicians try to use because it's better at identifying the higher risk population is called the Tyrer-Cuzick score. And so it gives you a calculated risk of developing breast cancer, I think over a 10-year kind of time frame. So you plug in all this information and it's kind of based upon, a lot of it's really based on history. So family history and BRCA mutations and things like that. Because that's what you're trying to identify is those patients who have the BRCA mutations or the P53 mutations or things like that. Those, you get breast cancer early and they're more aggressive. So it's ideal to catch those early. So what I would do is, for this patient, we're already kind of we're already past the point. So 52 years of age, right? So what I would say is get a Tyrer-Cuzick score on somebody. If it ends up being less than 20%, right, then you can feel pretty good at putting them into an average risk screening, meaning that based upon the guidelines by the ACS or the USPSTF, and it's annoying because you're like, which one do I go by? It kind of just depends. And I think a lot of this is kind of just provider preference and experience and being like a Zen experienced physician or PA out there. But really when it comes down to it, we say the ACS guideline says start at 45 and you can go to about 54 years of age and you can do these screening mammograms every year. And then once they get to greater than or equal to 55, you could do it every 2 years. And then we say once they get to the point where you expect that their life is nearing less than 10 years that they're going to croak, you stop, which is a hard thing to do, but at least it guarantees you that you may not miss cancer in a patient who's 76 or 77 who still could potentially live to 95. And so that's the ACS guidelines. And so again, just to recap, it's 45 to 54 every 2. Once they hit 55 and up, it's every 2 years. And then from there, again, you stop once we get to the point where there's less than 10 years of an average life expectancy. USPSTF is a little bit more simple, where it's you start at 50 and you go to about 75 years of age. And you do every 2 years. You'll do a screening mammogram. Once you hit greater than 75, you stop. And so there's obviously a lot of different things where people will argue on that stopping at greater than 75. And so it kind of just depends upon provider preference and instituting what those guidelines support. But that's average risk. So that's a Tyrer-Cuzick score or a Gale model that suggests they're not super high risk of developing breast cancer early.
Yeah.
That's why we start them a little bit later. If your risk is high, so your Tyrer-Cuzick score is like greater than or equal to 20%, that means you can get breast cancer a little bit earlier. You may have these BRCA1, BRCA2 mutations, TP53, PTEN mutations, all these different things that make your cancer become a little bit more high risk, more aggressive, and start earlier. So we want to catch that earlier. And so that's where we'll do the breast MRI. You'll start off with that, and then you'll also you try to rotate it. So you'll try to rotate the breast MRI and a screening mammogram, and you try to do it like every 6 months, but you're doing both of those every single year. So it's annually. And you can start at 25 or 30. It's like somewhere between that range. You want to start at least either at 25 or start at 30, but try not to start later than that. Yeah. And it's doing it annually with a breast MRI and a screening mammogram to see if you can identify a mass before it's 5 centimeters invading the chest wall, spreading to 17 lymph nodes, and you got it in your bones and brain.
Yeah. So that would be very helpful.
Yeah. So that's one way that we can try to identify cancer before it's really high, aggressive, advanced. Another thing that's really important with breast cancer is, let's say that, like, for example, let's say that you caught this patient early, right? Let's say that you had a small mass, and then you ended up you get a biopsy, and it shows like ductal carcinoma in situ, which I brought up, which is like a non-invasive one. It's still potentially, it's a cancer, but it carries risk, right? Or let's say this, not even ductal carcinoma in situ. Let's say that you have a patient, you get a Tyrer-Cuzick score, and their risk is greater than or equal to 20%. You could make the argument to say, hey, I want to screen you earlier. I want to do a breast MRI and a screening mammogram every year. But I want to offer you something to potentially reduce the risk of you developing breast cancer. So we can offer something called chemo for prevention. And it's oftentimes kind of thinking like, do they have risk of ER, PR positive, which is the most common overexpressed one. And so you can put these patients on tamoxifen. It's FDA approved. There's another one called raloxifene, but it's not as effective. And you can use aromatase inhibitors as well, potentially. But tamoxifen is going to be the big one. I'd say that's a really important one to remember. You can actually put a patient on tamoxifen as a chemo preventative agent to reduce the risk of that overproliferation. And every time you proliferate, every time a cell proliferates, you increase the risk of mutations. With mutations comes the risk of malignant transformation. So you can get close surveillance and chemo prevention to hopefully reduce the risk of mutations and malignant transformation of cells. So those are the two big things I'd say for trying to do that. One last one is really depends upon the patient. It's a little aggressive, but at the same time, I don't have breasts and ovaries, and so I can't speak to this. But if a patient is known to have a BRCA mutation, BRCA1, BRCA2, have a strong family history of breast and ovarian cancer, you could theoretically say, I just don't want to even take the chance. I don't want breast cancer. I don't want ovarian cancer. You could prophylactically remove the breasts and remove the ovaries and the fallopian tubes. And so we call it a bilateral mastectomy and a bilateral salpingo-oophorectomy. And it reduces the risk of developing breast and ovarian cancer pretty much like significantly. I think it's like a little bit over 90%. So that is something that you definitely can do. Again, it's aggressive, but it is an option, and I think it's more of the patient preference in these scenarios. So yeah, I think those are the big things. Is it comes down to screening, following the guidelines if you're average risk, following the guidelines if you're high risk, considering chemo prevention, and depending upon if you have these high risk mutations like BRCA, P53, things like that, you could consider getting these bilateral mastectomies and salpingo-oophorectomies.
And I'm sure just simple lifestyle modifications as well as maintaining a healthy body weight, limiting alcohol, exercising daily are your important for anything, not just breast cancer, for really any
Exactly. And those are modifiable risk factors. So like, for example, you can't, people who have risk of breast cancer, risk factors, a lot of the times it's non-modifiable. You can't control when you get your first menstrual cycle. So having an early menstrual cycle technically puts you at risk for breast cancer. Having menopause come later technically increases your risk for breast cancer. You can control if you get pregnant or not to a degree, but nulliparity, not having children, also increases your risk of breast cancer. But one thing that you can also consider is obesity increases your risk of breast cancer because it increases estrogen exposure over time. You can modify that. Lose weight, eat healthy can potentially change that. And then alcohol increases the risk of obviously mutations in general. So that also, getting rid of that. And then one more is people who are postmenopausal on hormone replacement therapy. Being on that for long periods of time and having a risk also increases your risk of breast cancer. Potentially saying, hey, do you need to be on hormone replacement therapy is another thing to consider that I could modify. But I'd say the most important things are definitely, as you said, exercise, preventing obesity, avoiding alcohol, and some even say protectively is getting pregnant. Those may have a potential risk of reducing breast cancer, but there's a lot of controversy around that. So yeah, I'd say those are really, really important things, man, to take away from it.
We talked about a ton of information in this episode, but that concludes it.
Yeah.
That's our episode on breast cancer. It was very informative. That was really a lot of fun. So thank you.
Yeah, man. I think a lot of the times when we think about breast cancer, the big key things to try to be able to remember, big pearls, is any patient who comes in with an irregularly, painless, enlarged appearing breast mass, have a suspicion of cancer until proven otherwise. Get your mammograms diagnostically to try to see, okay, what does this look like? And do you need an ultrasound as well? That's usually greater than or equal to 30. Less than 30, we just do the ultrasound. If it looks suspicious, BI-RADS 4+, core needle biopsy. From there, we can determine the type of cancer and determine what kind of receptor subtypes are overexpressed. And that can guide our targeted therapy. Again, based upon what stage they're in, is determined based upon the tumor size, if there's lymph node involvement, if there's distant mets. And depending upon what their stage is, determines how do we treat them. Stage 1 and 2, usually surgery, radiation is going to be the big thing, and just targeted therapy. But as you get to the more advanced stages, like stage 3, you may need to do chemotherapy beforehand to shrink the tumor, do surgery, do radiation, give them targeted therapy and chemo. And if they're stage 4, sometimes a lot of this is just chemo and targeted therapy with palliative approaches. But the most important thing to take away from this is that how do we try to identify this before it's too late? Yeah. Screening, knowing your average risk, your high risk populations, knowing the potential options you have for chemo prevention, and then knowing that sometimes prophylactic surgeries could come into play, and just trying to modify those risk factors that you're capable of modifying are really, really important.
Makes perfect sense. You crushed it, man. That was a really an awesome episode.
Yeah, man. I think it was really important. I think we as a population, we need to pay more attention and just evidence-based medicine directed to the boobies, bro. It's important. We need to be,
seriously,
they're far too important for science, for health, and for frankly all humanity. So get your priorities straight, people. Right?
Couldn't have said it better. That's beautiful. Yeah. But again, thank you for that episode. It was a lot of fun, and I guess it's just time for a send-off.
Yeah. So Ninja Nerds, I thank you guys so much for listening to this podcast. I hope that you guys liked it. I hope that you had fun. You learned a lot. And, make sure that you guys spread some awareness about breast cancer out there in the best way that you possibly can. And if you guys are interested, again, we have a lot of other things that we offer besides our podcast. Go check it out on our website. We have things like notes, illustrations, quiz questions, so much more. So I think there could be benefit there. But thanks for hanging around. Love you guys. Thank you guys. And as always, until next time.